guy way back in time. I don't remember if he was Greek or Roman, but he was credited with saying, things aren't always what they seem. That's clearly the issue with rheumatoid arthritis and steroid treatments. In 1950, the Nobel Prize was awarded to a couple of Mayo Clinic researchers and a third from Europe for the discovery of steroid treatment for rheumatoid arthritis. The steroids made a huge impact on the symptoms of the arthritis. Yet, what happened? Well, as things developed, you began to see prominent rheumatoid arthritis specialists saying you shouldn't use steroids for this. It helps with the symptoms, but it doesn't help nearly so much stopping the disease progression. In fact, so much so that CMS, when you look at the Hedis Part C measures, Hedis is a commonly used quality set of measures. Look at the last one here, rheumatoid arthritis treatment. Here's what they're talking about. Making sure that the patient is given a prescription for a DMARD, which is not a steroid. We'll tell you what DMARDs are in just a minute. In fact, here are some common ones. Methotrexate's one of the most common. Minocycline, Plaquenil, hydroxychloroquine. You may remember methotrexate is a commonly used anti-cancer drug, so it's got some significant side effects. Some of the quality problems that you tend to see on looking at this Hedis measure was that the patient was on prednisone, an oral steroid, not on anything else. In the reality, again, there's always debate about everything, and the current head of the rheumatology department at Mayo would say there's clearly still a place for steroids. There is. It's more of a transition from one DMARD to another and times like that. But what you tend to see in poor quality care is that the primary care doc who's not comfortable prescribing a DMARD, because these are serious heavy-duty drugs, is comfortable prescribing oral prednisone, which is very common, and they get great symptom resolution. So the patient just says, put me on the prednisone, and the doc leaves it. Meanwhile, the rheumatoid process, underlying inflammation, is continuing to have a big impact. So, in the Hedis scores, they look to see, number one, was a DMARD written? And number two, was it actually filled by the patient? Well, let's go back and ask a few questions. What is rheumatoid arthritis? It's the classic inflammatory disease. Our body's taking friendly fire from our immune system. This is a patient with it, and you begin to see a little bit of that classic, what the docs call MP joint ulnar deviation. Now, what does that mean? MP, metacarpal, these are the carpals and the phalanx. The P stands phalangeal, metacarpal phalangeal joints, the knuckles, basically. In rheumatoid arthritis, the immune system attacks the metacarpal phalangeal joints, as well as many other things, which you can see here. And you get what we call ulnar deviation. This is the radius bone. This is the ulna. You get deviation towards the ulnar side. That's what you see in this picture right here. But most patients are not that advanced anymore. We pick it up a lot quicker than we used to. Now again, what are the conventional DMARDs? Methotrexate, hydroxychloroquine, cyclophosphamide, phosphamide, sulfasalazine, several others. What kind of side effects do you get from it? Upset stomach, nausea, diarrhea, hair loss, muscle sores, liver, kidney, and lung disease. So again, as you can see, these are serious drugs. You tend to not get that kind of serious impact from just hitting the disease with some oral prednisone. So patients and doctors are both tempted to just, let's not mess with the big guns, let's just use prednisone. Why not do that? Because, again, rheumatoid arthritis is more serious than these serious side effects. Now, we talk about biological DMARDs. That's a new class of DMARDs, disease-modifying anti-rheumatoid drugs. They have problems too. And I'll list a few of them in just a minute in a couple of slides. Redness, swelling, itching, sinus infection, headache, nausea, diarrhea. In rare cases, some of these DMARDs can cause serious infections, tuberculosis, cancers, lymphomas. Again, these are serious drugs. So again, that sounds very scary for a rheumatoid arthritis patient to take. I mentioned that I was going to list some of the biologic DMARDs. Humira, adalimumab, canakinumab, canakinumab. These are like antibody treatments. Ilaris. We'll talk about Ilaris in just a second. It shows that connection between rheumatoid arthritis, the inflammatory diseases, and cardiovascular disease. But let's finish listing some more of these. Cosentyx, Xeljanz, tofacitinib. These are all, again, biologic antibodies to problems with the disease process. I said I was going to talk about canakinumab, or Ilaris. It's the CANTOS trial. Paul Ridker, he's the guy at Harvard who started a lot of this focus on the concept that cardiovascular disease might penultimate or next to last impact for damage in cardiovascular disease might actually be inflammation, more so than just relatively inert plaque. And one of the things he did was he tried methotrexate to prevent heart attacks and strokes. He tried canakinumab. Actually, canakinumab in the CANTOS trial back in 2017, I did a video on this. He gave thousands of people this on a randomized clinical trial. Guess what? Canakinumab actually decreased heart attack and stroke. In subsequent studies, though, they found that it really is not a good solution. Even in the first CANTOS trial, you gave up as many deaths associated with infections, assumably would have been managed by the more intact immune system had they not been taking canakinumab. And yes, that continued to be the case. So just another connection. You remember TNF alpha, tissue necrotic factor alpha? That's one of the inflammatory markers that we've studied and mentioned many times on this channel. Also IL-1, some of the others. Many of the biological DMARDs focus on these specific markers of inflammation. So again, is there a debate about use of oral steroids in arthritis? Yes, there is, but again, as you look at the trials, you may get some improvement in the disease progression, the X-ray, or disease progression as measured by X-ray and other things. But long-term, not like you get with the DMARDs. There's clearly a consensus that DMARDs need to be used. Why not steroids? Long-term side effects for relatively little long-term gain. Commonly used by non-rheumatologists inappropriately and in excessive doses. They get marked short-term symptomatic benefit, and that often tends to delay the long-term treatment. So again, when CMS puts these things in there, or Medicare puts these recommendations in there, when they adopt a recommendation from Hedis, the Hedis organization is not part of CMS. All of these organizations have looked at this and said, yep, we really need to watch this practice in medicine. So it may have gotten a little bit afield of what we usually talk about with cardiovascular disease, but for those of you who stuck it out this far, thank you so much for your interest. Winning is exciting, but you know what? What you're winning matters even more. How about the chance to win another couple of decades of life, healthy life, understanding the cause of heart attack, stroke, dementia, the major killers and disablers, and how to prevent those? You can win these courses to do just that. How do you do that? Click the link below, watch the video, answer the questions, and the more you answer right, the better your chances of winning. Give it a try. Win things like free courses that can save your life.